All right, you can go ahead and get started whenever you're ready.
Start share. So my title of my lecture is called Breast is Best. I am a breast surgeon that's practicing New Jersey, and I think it is absolutely the best field ever. And I hope that there are some future breast surgeons in the audience. So today I'm just going to go over my background, how I got to where I am. I'm going to talk a little bit about surgery and then talk a little bit specifically about breast, and then some advice for all the new who want to go to medical school, my future colleagues. So this is taken from my website. I am a board certified surgeon, which means I passed my step 1, 2, and 3, and then I did my general surgery residency. After that, I completed the written exam and the oral exam, so I'm officially board certified. So how did I get to where I am? I think this is probably like 7-year-old me to, here's a picture of me during residency, during one of my rounds one year. My mom wanted to see what I look like in a white coat because I never let her see what I look like. She usually sees me very disheveled in scrubs and some kind of hoodie, usually very, very sleep deprived. So I'm just like a normal person. I went to a public high school in New Jersey. I didn't go to any special science school or any private or boarding school. Then I went to Villanova University. It's a small Catholic college in Pennsylvania. I just majored in biology. I didn't do triple major or anything like that. And then during that time I was at Villanova, I actually was recruited to go to be the coxswain of the rowing team. So you can see here I am, and this is all my girls during one of our races. And while I was the coxswain, I learned a lot of skills that now are very important for me as a surgeon, and especially during residency. I intended on being a rower because I was a runner in high school and I wanted to do a sport, but because I was really skinny, they tricked me into becoming a coxswain, and it was a really good decision. While I was applying for medical school, taking my MCATs and getting my application ready, I knew I always wanted a master's of public health. And I took some medical school classes, which is a master's in biomedical sciences. So I did that while I was applying for medical school. And I did that at Rutgers University because I live in New Jersey. I was in a special program where the requirements for one course counted as the electives for the other. So I was able to get both masters in 2 years. Then I immediately went to medical school in Newark, New Jersey. It used to be called UMD&J, which is University of Medicine and Dentistry of New Jersey, New Jersey Medical School. Now it is called Rutgers Medical School. I spent 4 years there. I made the best of friends, and I would never trade it for any other school. It is a public university, so I saved a lot of money in tuition wise. Because it is in an underserved area, the medical students were very essential to the care of the patients. We had a free student-run clinic where we, as medical students, were able to help treat patients that didn't have insurance or that couldn't afford medications, and we were able to provide that for the patients. It's really nice. These are some of my closest friends from medical school, and we are actually still completely in touch. This person right here is actually the pediatrician for my daughter. So I'm in touch with her a lot. And the friends that I made in medical school are priceless, and they're all amazing people. After that, I went to Long Island. I went to Nassau University Medical Center. It is a county hospital, which means that we serve mostly the underserved patients, people who don't have insurance, people who may be in the country illegally. And because of that, we see a lot of bread and butter stuff as well, but we also see a lot of people with advanced disease who are afraid to get treatment. So we got to see a lot of diversity. In addition, we were a level 1 trauma center, so we got to see a lot of big accidents from the beach, and there are major highways in Long Island, so we see a lot of car accidents there. The center of Long Island is also the home to a lot of gangs, so we saw a lot of machete accidents that happened through. So my 5 years at Nassau University Medical Center was priceless because I got to see so much stuff in pathology. Here is a picture of me during graduation with our nurses, our attendings, fellow residents, our program coordinator, and significant others. So while we do work very hard, we know how to have fun as well. So it's not all boring. After that, after general surgery, you can choose to go into a fellowship. You can go directly into general surgery where you practice. You take out gallbladders, repair hernias, take out colons, and that's usually no additional training necessary. However, if you want to specialize like I did, you will need to do a fellowship. So from general surgery, there are many fellowships that you can do. So general surgery can be 5 to 7 years, depending on if you want to do any research years. And then after that, if you want to do a fellowship, it can be anywhere from 1 to 3 years. Or if you want to do additional fellowships, it can take a couple more years. So sometimes your training can take up to 11 years if you want to do general surgery and then do plastics and then do micro reconstruction. So it can take many years. Or if you want to do general surgery, then cardiothoracic, and then you want to specialize in the aortic valve, it can take up to 10 to 12 years. So most fellowships take 1 to 3 years, and depending on the fellowship, some people have to do additional years of research in general surgery so they can get into those competitive fellowships. So something like pediatric surgery, which is 1 to 2 years after general surgery, most of those residents have to do 7 years with general surgery because it is so competitive. So the fellowship that I decided to do was surgical oncology breasts, where I only treat the pathologies of the breast. So I treat benign and malignant. So anything with the breast is what I deal with. There are other specialties that you can do as a surgery resident. You can do cardiothoracic, where you just focus on the chest. You can do colorectal, where you focus on the colon and the rectum. You can do trauma and critical care. You can manage the ICU. You can do plastic and reconstructive surgery, which is 3 years. You can do pediatric surgery, where you just operate on people under 18. You can do endocrine surgery, where you focus mostly on the thyroid and the pancreas and the adrenals. You can do transplant surgery, which is another 1 to 2 years. So this transplant is usually kidney and liver transplant. You can also do MIS bariatric, which is minimally invasive surgery, where you try to do all of general surgery all through small laparoscopic ports. Also in general surgery, you can go into hand. It's rare. Usually people who go into hand are coming from plastic surgery or from orthopedics, but from general surgery, you can go into hand surgery. These are just some of the options. So now I'm going to go through some of the cases that I saw in Nassau University Medical Center in Long Island during my 5 years as a resident. So this is a case that we saw while we were on plastic surgery. This is a young woman that had this cutaneous growth on her forehead. It is a horn. So this is probably one of 4 cases that are described worldwide. The plastic surgeon took her into the operating room, was able to remove this mass and then close her skin. This is another case that I saw while I was on my trauma rotation in Long Island. This is a grandma who had an altercation with her grandson, and then he stabbed her. So this is a fork that went into her left shin, and this part around her is just her clothing that remained there. We gave her tetanus shot, gave her some antibiotics, made some x-rays and some CT scans to make sure no important vessels were damaged, and then we removed the foreign object. This was a consult that I saw while I was in the emergency room. This was an 18-year-old boy that was playing with his carbon dioxide cartridges for those carts, and he fell on top of it. So often, as a general surgeon, we will be called from the ER to remove lots of foreign objects that are jammed up the rectum. So luckily for this gentleman, we were able to just give him some sedation, place a large clamp up, and remove it without any surgery. So this is another consult we got from the ER. This is a larger soy sauce bottle that is also in the rectum. So this is a picture if you're looking directly onto him. This is the pelvis and these are your hips. And this is a side view of the object. So this is a soy sauce bottle. So unfortunately, this patient, we could not take him, we could not remove it at bedside because it's much larger and it was hard to remove because of the suction that was created by this object. So we had to take him to the operating room, cut his abdomen open and then cut his colon open, remove the object and then sew him back up. This is another consult that we got from the psych department. This is a person who has a disorder where he eats objects, and we were being consulted because of all the things that he swallowed. These are different stones. This is a lighter. This is a nail, and there's some rocks, and here is another nut. So these objects can cause an obstruction. So we were following him. We didn't give him anything to eat. We examined his abdomen and we were giving him x-rays every day to make sure that his bowels were not getting super dilated because it was getting backed up. Luckily for him, he was able to pass everything and he did not need any surgery. Sometimes in general surgery, we are called by our other colleagues for assistance. So this is a case where a urologist was taking out a large kidney mass for a cancer. However, the mass ended up being attached to the colon. So we were called in to help remove the mass from the colon. And then the final specimen that came out was, this is the kidney and all of its growth, and this is the size of my hand. So we do work very closely with our other colleagues like the urologists, the OBGYNs, and trauma or orthopedic surgeons, and we work together and help each other out whenever it's necessary. This is a case where we were working in the trauma bay and we had a really bad car accident where somebody's heart stopped beating. So this is a rare case where we did something called an ER thoracotomy, where we open up the chest in the emergency room in attempts to get the patient back alive. So sometimes their heart stops beating and they don't have enough blood. So we open their chest, we clamp the aorta, and we do open cardiac massage in an attempt to get the person back alive. The success rate of this is very low. It's less than probably 3%, but we have gotten one person back alive through these heroic measures. So this is just me walking one of my juniors through an ER thoracotomy. We also rotate on pediatric surgery. Sometimes in rare cases, children will be born with their intestines outside of their body. When you learn in embryology, as the fetus is developing, their organs go outside the body, do a rotation, then come back into the belly, and then they close and then they're delivered. In rare cases, the intestines do not come back into the belly. We can see that on fetal ultrasound. So this mom and child were born via C-section. And then when he was born, all of his bowels were outside his body. So we were there, part of the delivery, along with the the NICU team. We immediately put this silo, which is just a plastic covering around the intestines. And then we put a little circular plastic thing around here to help keep it open. And every day we go by and we clean his abdomen and we try to attempt to get all the intestinal contents back into the belly. So if you look every single day, there's a knot here, there's a knot here, there's a knot here, a knot here. So in about a week, we're able to get all the intestines that were outside of the belly back into the belly. And then we're able to take the patient to the operating room and close the defect and create a nice small belly button for him. Usually these children do great and don't have many problems afterwards. So if you don't like looking at things that may be a little gruesome, I would suggest that you look the other way for a second. This is a gentleman who was driving a truck. He was under the influence and he got into a really bad accident. And this is one of the traumas that we will get while we are on Long Island. And in this time, the trauma team is involved, the ER is involved, the vascular team is involved, and the orthopedic team is involved. So please turn away if you do not like looking at things that may be gruesome. But this is a mangled extremity of one of our trauma patients. This unfortunately was not salvageable, so we had to do an amputation for this gentleman.
Very interesting.
So after my 5 years in Long Island, I went to New York, where I did my 1 year of breast surgical oncology. During that year, I only focused on breast. I focused on benign and malignant pathology of the breast. And at the end of the year, I presented at the National American Breast Surgeon Society meeting, and that year was held in Austin, Texas. Here I am with my co-fellow and our program director with our posters. So some of the benign things that I treat of the breast include cysts. And these are things that I can do in the office. This is an ultrasound of a patient. This is my actual patient. Here is a cyst, and then I aspirated it with a needle. So I just put a needle in and I'm able to drain all the fluid out. I think this one was probably like 5 cc's. It relieves the patient of the mass and the pain, and it's very satisfying and it's easy to do by the bedside. Here is something that I removed from a patient's breast. If you look at it, this ruler down here is 15 centimeters, or it is 6 inches. So this is a growth that a patient had in their breasts. We biopsied, it was not cancer. However, it kept on growing and growing and growing. And when we do a biopsy, we're always worried, did we miss the other part of the mass, which could be cancerous? So we ended up removing it. This is a juvenile fibroadenoma, which is a benign growth of the breast. We had to take it out just because it was growing so fast to make sure there was no cancer. I have another picture that may be a little shocking for some people. Sometimes we get called to the hospital because a patient fell or lost consciousness, and then during their physical exam, they discover a fungating mass. Usually 99% of the time, a fungating mass is breast cancer until proven otherwise. The patient has been ignoring this for probably 10 years and it's been getting bigger and bigger. It's foul smelling, and it also is sticky and is weeping. And then we get called to evaluate the patient. So if you don't like looking at things, look away again. Here is a picture of a woman's left breast, and this is a fungating mass that she was ignoring for many, many years. So as a breast surgeon, we are called to the bedside to evaluate this mass, evaluate her lymph nodes, and then we take a sample of this tissue to see the biology of the mass and see how this mass will behave. It did come back as breast cancer. However, knowing the markers of it and how the breast cancer behaves helps us target how to treat the patient. So as a breast surgeon, this is how my average week is. I have 2 days where I have office hours. I see new patients, I see follow-ups, and I do ultrasound procedures such as biopsies and cyst aspirations. New patients could be anything from breast pain to nipple discharge to new masses, or just family history of cancer or personal history of cancer. Follow-ups, I could have operated on somebody and then I see them every 3 to 6 months. And then I usually follow up a cancer patient for up to 10 years. If somebody's high risk for breast cancer, I usually follow them up for life. The good thing about my specialty is that, as most surgeons, they operate on them and they never see them again. If somebody has a gallbladder, they take it out and they probably never see them after a year. If somebody has a hernia, they fix them and they usually don't see them again. But in breast, it's unique that we do take care of them surgically, but then we do follow them up. So I like this aspect of continuity of care. So it's a little bit of medicine with the surgical aspect as well. Other 2 days of the week, I am in the operating room where I perform mastectomies, which are removal of the entire breast, or partial mastectomies, also known as lumpectomies, where I remove a portion of the breast and I reconstruct the breast so it seems like I was never there. And then I have one day of the week where I do my admin work and I prepare all my charts and review the paperwork. So here is a picture of me and my fellowship cohort year. They flew us all to Houston, Texas, where we did cadaver labs, where we got to see all the new technology about breasts. The good thing about breasts is that it's constantly changing. There's so much research going on, and we're having better and better treatment for breast cancer. And this is why I think breast is best, because we're always learning and we get to treat the surgical and the medical aspect of the patient, and there's continuity. So how did I choose breast surgery? I knew I wanted to go into medicine. I knew I wanted to help people. Before I went to medical school, I thought I wanted to be a pediatrician because growing up, that's the only doctor I really got to see. And I saw how she gave lollipops and stickers and then, you know, still treated me as like, wow, this is a cool job. This is something I want to do. And I always thought I wanted to be a pediatrician. And then when I got into medical school, when I was in my first year, I got into an anesthesia scholarship that allowed me to do research with the anesthesiologist. This was my first experience in the operating room, and I absolutely fell in love with the operating room. I loved being in there. I loved the atmosphere. I loved that we were able to take patients in that were very sick, take out whatever was wrong with them, sew them back up, and then they would do better. I just loved it. So I thought I wanted to do anesthesia. I did a lot of anesthesia research. I did a poster. I even went to the National Anesthesia Conference. During my third year, that's when most medical students get to go on all their core rotations. I realized that I actually loved surgery and not anesthesia. Anesthesia and surgery both are able to go into the operating room, but I liked looking at the surgery side where all the action was happening. So as a woman, I was strongly discouraged from doing surgery because you can't have a life. They said that you can't have children. You will never get married. Who will ever want to date a surgeon because you guys you have that stereotype of being that loud woman that is really strong. I ended up doing a 3-month sub internship in my 4th year. And I told myself if I could survive those 3 months, then I would apply for general surgery. And if I couldn't, then I might apply for anesthesia and emergency medicine. The hours were rough. I would be there at 5 a.m. Sometimes I would not go back home until, 10, 11 o'clock at night, but I was happy. I was so much happier. Even if the hours on psych were so much better, I was so bored. I was sleepy all the time on psych. I realized that surgery was my calling, and I was willing to put in the 5 to 7 years that may be necessary for surgery residency. During my surgery residency, we had a grant from the county where we helped underserved women, and we were giving out free mammograms to the women of Nassau County. So because of that, we did have a breast clinic that was every Tuesday where we took care of the women that got the free screening. In breast, it is a specialty where it's multidisciplinary. As the surgeon, we are usually the captain of the ship, but we also work in close conjunction with the medical oncologist, the radiation oncologist, the radiologist, the genetic counselor, the physical therapist, the plastic surgeon. And I love that aspect of breast, that it's not just me, but a whole team of people who get to work on the patient. In addition, like I said before, with breasts, after I operate on a patient with cancer, I usually follow them up for at least 10 years. So it's not like other specialties where I take out their appendix and bye, I never see them again. So I enjoyed that aspect. And for breasts, I usually see patients every 6 months. So for me, that was good enough that I get to see them, but not too much. For some specialties, you see them every 2 months, every 1 month, and that might be too much for me. So the way that a breast surgeon sees their patients was the perfect amount for me. So for all you future med students and future colleagues, I recommend that you guys shadow, and like what you guys are doing now, go on as many lectures as you can. Make sure you really want to do this, because medical school is not easy. If you did not want to do it, it's pretty terrible and very torturous, and also a waste of time and a waste of your money. You really want to make sure that this is something you want to do. not because your mom or your dad or somebody else wants to do it. Make sure you want to do it, because otherwise you will be absolutely miserable. Make sure you take your pre-med courses, your bios, your chems, just take them all. I probably don't use half of them, but if I do need to read up on a journal, I understand how to do it and I know where to look it up, and that's why they want you to take all those pre-med courses. Make sure you take your MCATs. I'm really old. I took my MCATs on paper. So right now I know the MCAT system is a completely different scale. So I can't really help you on that, but make sure you take your MCATs. Make sure to also participate in extracurricular activities. We don't want to see the same person applying for medical school. We want diversity. One of my senior residents played the clarinet at Juilliard. So she was an older applicant, but they loved that there was diversity. I had another classmate who was a musician. I had another classmate that was a lawyer. It's nice to see people from different backgrounds coming together and making sure you do other activities to make sure that you're just not just studying, that you're a well-rounded person. Be persistent. Medical school is now very, very competitive. I don't even know if I will get in if I apply now. You guys are all so smart and so talented. So keep on trying. And also, if you reach out to people, make sure you're professional. I've seen people reach out to some of my colleagues and just address them like, hey, Helen, how are you doing? Be professional. Be like, dear Dr. Smith, blah, like, just be professional, because if you're not, people will take note and it will hinder your chances of getting into medical school. When you go for your medical school interview, everybody's looking at you, from the secretary. If you do something bad, they will tell the dean, and then that will lower your chances. Just be nice to everybody, be professional, and be persistent. And that is it. Good luck with you guys. If you guys have any questions, feel free to reach out to me. I'm a little older than you guys, but if there's anything I can do to help, please let me know. Don't be discouraged. Just keep on trying. And that's it.
Okay, yeah, thank you so much for the presentation. That was definitely really inspirational. I learned so much about that. If anyone has any questions at this time, you can feel free to drop them in the chat or unmute yourselves. I can stop recording if that makes people more comfortable.